is Ubiera Minaya, and I'm the Executive Director for Amplify Latinx. I hope that you have your cafecito in hand and that you are ready for this conversation, because that's what this means this morning. Is a way of coming together and interacting and making sure that we are providing a space to talk about important issues. So I'm gonna tell you just a little bit about Amplify Latinx. We are a nonpartisan collaborative movement, and our mission is to build Latinx economic and political power by significantly increasing Latinx civic engagement, economic opportunity, and leadership representation across sectors in Massachusetts. We are one of the largest Latinx networks in Greater Boston, and we have over 6,000 active participants, and those are representatives of emerging and just established leaders, business leaders in our communities, as well as community partners and corporations. Our goal is to serve as a leading voice and advocate for our Latinx communities across Massachusetts by building a diverse, unified, and powerful network of leaders and partner organizations. We focus on economic opportunity, civic engagement, and leadership representation. With that said, I wanted to tell you a little bit about today. Again, this is meant to be a very informal conversation and an exchange with our panelists. And you're gonna hear more about who is in this amazing panel this morning, but I just wanna go over a little bit of logistics. By this time, we all kind of like know Zoom, but I just wanted to make sure that you know that you will be muted during the session while our panelists are introducing the topic. And then we get a chance to ask questions and chat. But if you have a pressing question that you wanna make sure that comes through, or a reaction or a comment, you can just put it on the chat. And this session, as you heard, is being recorded, and we're gonna share it after the event. Also, make sure that you follow us on social media. There's Alan is gonna put on the chat our social media handles, so you can give us a shout out. It's always great to be able to share the amazing experience that we are having today. So today we are talking about equity, mental health, and the Latino community. So this discussion is, I'm sure it's gonna be amazing, because look at that panelists that we have the honor to be with this morning. I'm gonna introduce our moderator for the morning, and I'm just so proud and excited to introduce a leader, a Latinx leader that I admire so much, and that has been such a crucial person to the Amplify Latinx community. Dr. Dharma Cortez. She is at the Health and Equity Research Lab, and she is gonna take us to this conversation this morning. Dharma, take it away, the floor is yours.
Gracias, Rosario. Buenos días. There are a few reasons that made me very happy to be here. The first one is that back in 2012, 9 years ago, I attended the very, very first Cafecito that eventually evolved to become this wonderful organization, Amplify Latinx. The second reason is that I am also a very proud member of Amplify Latinx advisory group. And the third reason is because I am very pleased to be here among familia and amigos, Ben Cook, Mike Flores, and Danny Jimenez. They all are longtime colleagues of mine for over 15 years. And as Rosario said, I'm going to facilitate the conversation that is focused on the work that we do to reduce health disparities. The topics that we will cover this morning, as Rosario also mentioned, are mental health. And we're also going to be talking about the impact of COVID-19 among Latinos. But before we begin this conversation, I would like to briefly share with you some biographical information about our three panelists. The first person is Dr. Benjamin Leck-Cook. He's the director and my jefe of the Health Equity Research Lab at Cambridge Health Alliance. He's an associate professor in the Department of Psychiatry at Harvard Medical School and a visiting clinical associate professor at the Albert Einstein College of Medicine in the Bronx, New York. Dr. Cook is the health services researcher focused on improving quality of life and access and quality of treatment for individuals living with mental illness and substance use disorder. His research tracks healthcare disparities in the US and the impacts of health reform on disparities. He also seeks to understand discrimination in the patient-provider interaction, and he also evaluates the impact of hospital-based interventions on health equity. Dr. Daniel Jimenez is a clinical psychologist and an associate professor in the Department of Psychiatry and Behavioral Sciences at the University of Miami Miller School of Medicine. He has extensive experience in aging research, and he has dedicated his career to improving access to and engagement with mental health services among underserved populations. Dr. Jimenez's research interests include geriatric mental health services research, health promotion, multicultural mental health, and mental illness prevention. He has received multiple federal grants to design and implement culturally appropriate and novel approaches to preventing mental illness in racial, ethnic, minority, older adults. Then we have Mike Flores. Dr. Flores is an instructor in the Department of Psychiatry at Harvard Medical School and a research scientist at the Health Equity Research Lab, also at Cambridge Health Alliance. His research uses rigorous analytic methods to inform policy development, clinical practice, and allocation of limited resources to improve the health outcomes and care quality of racial, ethnic minorities with mental health and substance use disorders. Dr. Flores completed a postdoc fellowship at Harvard Medical School, Cambridge Health Alliance, and received his PhD in health services research from Brown University. As you can tell, by these very brief bios, they're quite accomplished and has spent many, many years trying to figure out many of the challenges that Latinos face as they seek mental health services. I want to begin by asking Ben a few questions, and I hope that you also have many more questions to ask these three panelists. So Ben, can you tell us what are the mental health issues that are most common for the Latino community here in the United States?
Well, thanks for that question, Dharma. And I'm so glad to be here. Thank you, Rosario, and everybody from Amplify for inviting us to be here and to give us some space on this panel to talk about mental health. So, there are a lot of issues related to mental health in the United States. We could start there. Unfortunately, a lot of us and our family members experience problems with mental health. When we do community surveys, when we go out to the community and ask rigorous questions about individuals' mental health symptoms and their functioning, we find really high numbers. So about 1 in 5 of us sometime this year will have problems with depression, anxiety, or even more serious mental illness. Over our lifetimes, what the data shows is that 1 out of 2 of us will have a year or some time where we're having real trouble with depression, anxiety, or other mental health issues. So the rates are kind of astounding compared to other types of illnesses. It's that a lot of us and our family members, and I'm sure some of you know individuals who are struggling with mental health problems and addiction. And it just impacts a lot of us in the United States. For Latinos, the data shows that the rates of depression, anxiety, and some of the more serious mental illnesses are similar or maybe lower in terms of lifetime or last year prevalence of these mental illnesses. But I want to make a really important distinction that for those individuals who do have mental health problems in the Latino community, they're seen as more persistent or severe. So that's where there's a disparity, if we were to call it that, in the Latino community, is that compared to whites and compared to some other racial and ethnic groups, Latinos have depression symptoms, loss of function, anxiety symptoms that are more drawn out. They last longer than other communities. And the severity with which they have these depression and anxiety symptoms can be much more difficult and stronger than other communities. So that's one point that I really want to highlight, is that if we were to look at a disparity in the Latino community, it's not that the Latino community has depression or anxiety or some of these other mental illnesses more than other communities. It's the persistence of the mental health problems and the severity of those mental health problems. So that's maybe one point I can highlight. That I could talk about some others, but maybe I'll start with the next talk.
So, and can you tell us, Ben, in light of these persistence and level of severity of symptoms, how do Latinos compare in terms of seeking out help for or treatment for these conditions?
Yeah, thanks for that question, Dharma. This is definitely an area where there is also a disparity. If we are thinking of places where the community needs to gather, where policymakers need to address disparities, that difference between the Latino community and other communities this is where there's a real disparity. So you can think of this as a 2-to-1 disparity. Among those individuals who really need help, the Latino community seeks care about half as much as the white community. And there are a lot of differences between the sub-ethnic groups in both the white and Black and Latino community. But again, looking at the data overall across the country, what we find is that only about half of the people that have mental health issues seek care in the white community. But what it looks like in the Latino community is more like 25% to 30% of them seek treatment when they really need treatment. So some of these national surveys, they look at psychological distress, which is made up of problems with sleep and appetite. And they look at depressive symptoms, which are problems getting out of the house, symptoms that a lot of us have had during COVID. But when you start to hit these symptoms at a very high level, and it reduces your function, your ability to go to work, your ability to go to school, then when you look at those individuals where they're really losing function in their families and schools and work, that's where we see only about half of them receive treatment in the white community, and only about 1/4 of them in the Latino community, or 30%. And when we get to kids, to youth, it's even lower. Those rates are even lower. So if we were to find a place where disparities are large and we really want to find policymakers who can get behind this, I think it's there. We need to figure out better ways of treating the Latino community that are really having difficulties with mental health or addictions.
So I have one follow-up question, and then I want to turn to Danny. Amongst those who seek and secure treatment, how many stay in treatment for perhaps as long as they need?
Well, here's another problem with the mental health treatment system, is that very few people stick around. And so that's the short answer, Dharma, is that our mental health treatment system is just not set up very well for folks who need treatment. Our studies have shown, using national data, again, in the general population, that very few people have more than one visit. So what does that mean? We've talked to community members, and community members have said, there are so many hurdles to getting that one visit. Remember, only 25 or 30% make it to that first visit. There are so many hurdles. There's insurance hurdles, there's finding time out of work, there's transportation issues, there's how much do I have to pay out of pocket? And then they finally make it to the provider's office, and the provider asks them questions that don't seem relevant, because they have to do some kind of structured instrument. They ask them a bunch of questions that don't seem relevant to their problems. and they get really concerned. They feel like they're being discriminated against. This comes from a lot of the community members that we've talked to, is that first visit just doesn't feel right. It doesn't feel like they're addressing their problems. It doesn't feel like they're able to tell their story in the way they want to tell their story. And so they don't come back. So about half of the people that initiate treatment only go for one visit, which is just a shame and a real problem with the mental health treatment system. We're just not doing enough to keep people in treatment. And for the Latino community, those numbers are about the same. We need to do a better job in finding people who understand, and Danny will talk about this. We need people to understand the community, that speak speak Spanish, speak the right language, and speak the language of the community so that they stick around and that they don't ask questions that seem irrelevant, and they give them space so they can tell their story and the reasons why they came in for treatment.
I still have one more question.
Okay, that's all right.
I was not being truthful. I want the audience to have an idea of the data that you analyze to inform these questions that I've been asking you. Can you tell us about when you say Latinos, when you look at data, how many data points, how many people are we talking about when you embark on these data analysis? I just want people to have a sense of the kind of data that you analyze to come up with these observations.
Yeah, thanks, Dharma. These are studies that are huge efforts done by the US government, done by academic researchers. There's a lot of investment in these surveys. And so as an example, we often use the National Survey of Drug Use and Health to look at addictions. That survey, what they do is they randomly sample over 50,000 people every year across the country. And they randomly sample it so that you can use that data in order to make predictions, to identify prevalence of some of these illnesses for the entire nation. And that's a big enough sample to identify what Latinos are facing in terms of mental health and substance use. So think about 50,000 a year at least, and then we multiply that by many years of data. We have 20 years of data. So that's one way of thinking about it. We also look at claims data for Medicaid, for example, and there we have millions and millions of Medicaid beneficiaries across multiple states. So yeah, these aren't just taking folks who have come into treatment. This is looking in the entire community, randomly sampling thousands and thousands of Latinos and asking about the issues that they have.
Great, thank you. So Danny, can we prevent mental illness?
Well, first, let me say, excuse me, sorry. Thank you, Dharma, Ben, for inviting me. I'm all the way down in Miami, but I used to live in Boston, but now I'm all the way down in Miami. And so I'm really happy to be part of this panel. And that's a really good question, Dharma, because over the last 20, 25 years, it's been sort of like a niche topic. It's sort of gone from like, is this possible, to now actually like real data showing that yes, in fact, we can prevent depression, we can prevent anxiety. And the way we do that is through a number of different ways. We start off broadly, right? We sort of taking like a universal approach where, think about it like we put fluoride in the water type of thing, where we educational programs to get people more active, more physically active, educational programs or just programs in general to get people to sleep better, raising awareness of mental illness. Just those types of things lead to greater awareness of mental illness, and then eventually preventing or at least mitigating the effects of mental illness. Then from there, we move towards a more targeted approach where we look at people who are more likely or more at risk to develop depression. So people with, let's say, diabetes, and we know diabetes and depression are co-travelers, as my mentor used to say, that they go hand in hand. And oftentimes when people have diabetes, they also have depression, or when people are depressed, they also have diabetes. And so it's it's addressing those folks who have diabetes even before the depression symptoms start arising to intervene at that level, and then hopefully stem the tide that might come. And then finally, even greater is when people start to experience symptoms of depression or anxiety, but they're not at a level where they can be diagnosed as having major depression or, let's say, generalized anxiety, intervening at that moment in time to address those symptoms so that the course that we know will follow stops, and then they can and we prevent sort of those downstream effects that we know will happen.
I want to follow up with another question, and Ben said something a little bit about kids and Latinos in general. What are some of the differences that you see between younger and older Latinos when it comes to mental health issues?
Well, there's quite a few differences. When you look at the data and you combine young Latinos and older Latinos together, the picture shows that Latinos are actually less likely to have depression. So the prevalence of depression and anxiety is lower. But when you start bringing it down by age and you look at specifically the older Latino community, the prevalence rates of depression and anxiety are quite high, and they're actually equal to that of whites. And so that's one. Another one is the health beliefs and the stigma that is attached to mental illness is very strong in this section of the Latino community. And also the risk factors for mental illness are greater, I would say, in this community, because there's a lot more isolation. There's a lot less sort of fluidity because there may not be the language fluency, right? Like the confidence in speaking English. So that tends to isolate these folks even more. So some of these so they don't have the ability to socialize outside of the family environment, right? Whereas younger adults, they go to work, they go to school, they have friends out in the community. Whereas these folks, because of the language and also maybe because of transportation issues, can't get out of the house, or their social circle is much more limited.
Great. So let me turn to Mike. Mike, based on what you have studied, would you say that where we live influence mental health?
So good morning, everyone. Thanks for that question, Dara. So yeah, I would say that where we live definitely affects our mental health. You could think about this something like the social determinants of health, right? Like these are like upstream factors that contribute to mental health. So not so much interpersonal, like who you are in terms of gender, age, race, ethnicity, but more so think of it like as your neighborhood level or higher up factors that contribute to your mental health. So you could think about these maybe breaking these up into different buckets. Something like psychosocial factors could contribute to mental health. So when you think about psychosocial factors, well, what are psychosocial factors? So that's simply like social cohesion, social support. Think of it as like your neighborhood Y, where you go and you interact with folks and you play basketball, you meet with one another. That kind of camaraderie kind of helps with your mental health status. And conversely, the lack of these things can also could be a factor that contributes to mental health, because you don't have that ability to congregate with folks, socialize, things like that. There's also environmental factors that can contribute to that. So think about that as for folks that live in urban areas, think of noise pollution, things like that, or air pollution, things that increase your stress level. These kind of contribute to increasing feelings of anxiety, depression, things of that nature. And also think of economic factors contribute to this. The availability of jobs in your neighborhood also contribute to such things. Economic status, what the neighborhood looks like, the resources that are there, whether you have access to to healthy foods, or access to other things in that neighborhood. So another bucket could be health-related factors. So meaning just access to like a clinic, access to community mental health centers. All these kind of different factors could be helpful in the sense of if they exist, they would help aid the individual with their mental health status. Whereas the lack of these things, studies have shown may contribute to poor mental health status. So these are some of the factors that can contribute.
And Mike, do you come up to these conclusions based on large data sets that you look into? Can you tell us where all these data come from that allow us to say what we're saying about how the environment impacts mental health?
Great question, Dharma. Definitely. So this is something similar to what Ben was talking about, kind of using these large data sets to kind of look at prevalence rates of mental illness among Latinx populations. So what researchers do is like they combine multiple data sets to look at these things. So they combine not only like these surveys where they go out and ask these questions about your mental health, substance use, and things of that nature, but then you start looking at combine that with geographic factors. So they link these data sets with like the census, these large data sets that collect tons of data on folks. And so that's when you start getting things of that nature, understanding where these services are and how people are placed in these locations. So it's all very big data that exists, that's out there, that's collected from folks like you. And researchers just kind of analyze it to get down to understand how these different factors are associated with one another.
Great. So I want to turn the conversation now and bring another important factor that has impacted people's mental health, and that is COVID-19. Can you tell us, Mike, how from your studies, how do you see COVID-19 impacting the mental health and substance use disorders among Latinos?
Well, the pandemic has hit folks very hard, especially the Black and Latinx communities. And so, so think about it from the perspective of once a pandemic hits, a lot of folks, there was quarantines and social isolation started happening immediately in order to prevent infection, to decrease infection rates and transmission between one another. So when you start isolating folks, it's like, it depends where you are and kind of like your living situation primarily. And that could either be very isolating if you're a single individual in a community and now you would normally go outside to access, talk with friends and socialize. Now you're by yourself indoors. And so that limits that. And so your idea of anxiety kind of increases, one. And another, if you are the opposite, where you kind of go home and you're like a multi-general household, no longer do you have any privacy. Now you're kind of confined with like, not only like your brother, sister, your mom, dad, but your abuela, your abuelo, your tia, your tío. So it's just like this combination of folks where now it's like, it's the stress that starts kind of coming up because where can you go for that privacy? So it's that kind of like the confluence of these factors, in addition to the fact that there's this idea of fear and distress, because it's like, who's being affected? It's your community, your neighbor, and so all these different factors kind of increase the feeling of anxiety, stress, and depression. So I think that's where a lot of it comes for mental health. And from a substance use standpoint, for example, let's think of folks that are addicted to opioids, for example. The opioid epidemic has been really hitting hard, in this wave among Black and Latinx populations. And so during this time, it's like a lot of these folk are going out for like, let's say like methadone treatment. And a lot of these things, people have to show up on a daily basis to this facility to access their medication. And so now that, folks are being asked, everything's closing down and they have to be indoors, these people are no longer easily accessible to these services. So things have had to change a lot in order for to address some of these barriers and problems. But this is some way how the COVID pandemic has kind of affected these populations in some ways. There's a host of more, but that's just a little glimpse of how some folks are being affected.
Thank you. And Danny, how are you seeing the COVID-19 pandemic impacting older Latinos?
So one of the things, and I mean, it's very similar to what Mike said, you know, in terms of the social isolation, right? That at least here in Miami, one of the things here in Miami that was very common was we have a very robust parks and recreation department within the county. And then in some parks, they actually have like Domino's tables set up. And so a lot of older Latinos would come, they would sit down. It's kind of like those chess tables out in Central Park, right? Like, and then, but these folks would come and sit down and play dominoes, but they would also have comedores too, which is like in the clubhouse that sits in the park. They would provide free lunches, and then they would also provide different sorts of activities, whether it was bingo, sometimes they would do Zumba. So all of that sort of went away when the pandemic hit. And so like the one lifeline that a lot of these people had was now taken away. And so, you know, they were stuck in the home. And so, you know, alone without having much of an outlet during the day to actually like meet and do their normal activities. That was one. But also because of that, right, their physical activities also lessened. So they wouldn't go outside and they wouldn't go for a walk. They wouldn't. So all of a sudden now this population that was already at risk because of all these other factors, now they're a lot less, they're a lot more socially isolated. They're a lot less physically active. And so that's just made their health and their mental health just really decrease. And then finally it's diet, right? So at least here, my experience has been, you know, when the food is really important to bring people around, right? It has been used to really engage, to really promote the socialization, whether it's between families, whether it's within families or between families, within, you know, between friends, that sort of thing. But the Cuban diet really is lacking in vegetables and in any sort of balance. It's just really heavy in rice, and then you got your meat, and that's what it is. And so that it went from they're still eating that, right? But there's not the outlet for there's no outlet for physical activity, and then the stresses that come with it lead to increased eating. So what we're seeing now is an increase in all these other risk factors like obesity and cardiometabolic disorders now starting to increase. And again, that leads back to mental health because these are linked.
Great. There's a lot of conversation related to the use of telehealth during the pandemic. And this question is for either one of you. How do we see Latinos using telehealth during COVID for mental health issues? Have we seen any changes in the way that they show up for treatment? And I'm also thinking about the issues about connectivity. You know, when we know, I myself have been doing interviews with with different Latino communities around the impact of COVID-19, and sometimes, you know, they have told me about the challenges with internet connection. So I'm curious to hear about the use of telehealth services among Latinos, especially during this pandemic and their need for mental health services. Ben, you want to answer that?
I could start.
I just volunteered
yeah,
you.
Mike has looked into this a lot at our institution at Cambridge Health Alliance, and Danny has firsthand experience as a clinician working in telehealth. But my general understanding from looking at qualitative interviews, and Dharma, you should chime in here, a lot of my understanding comes from you, and then looking at electronic health record data and other data, is that it's a real mixed bag. telehealth offers the opportunity for folks who have always had trouble getting into visits because of their work. A lot of them are working multiple jobs. They're not working 9 to 5. They might have after hours jobs. So it's just really hard for them to find hours if they're working all day long to go into the therapist's office, which might take a couple of buses, which requires a long wait. But telehealth during COVID has allowed folks to take a half an hour call on their phone or get in front of a computer screen for a half an hour. That's a lot different than 2 bus lines and the red line to get to your appointment. Instead of the 2.5 hour taking off of work, now you just have to take a half hour. So in that way, telehealth has improved access to these treatments and mental health treatment. The downside of telehealth is you're kind of losing, and this will be obvious to many of you, is you lose that in-person contact. And especially for mental health treatment, when you're trying to have an engagement between a provider and a patient, it just takes so much to build trust. And especially for folks who have been discriminated against in the past, folks who have had horrible experience with providers feeling like they were being racist towards them. Now you have this over a screen where it's hard to identify body language. It's hard to, maybe it's just over the phone, so you can't see their face very well. And so building that trust and engaging the patient and provider ends up being really difficult with telehealth. So this seems like a mixed bag in some ways. Like there could be a lot of great things about telehealth. It can be much more convenient, but providers also need to be really good about building engagement and trust over this unusual medium.
I also know that you look into payment, healthcare services payment. How are insurance companies or private insurance companies and Medicaid, Medicare, what are they doing about this telehealth? Are they supporting it and paying for these services as we hopefully come out of this pandemic? How are these services being paid for through health insurance?
Yeah, if you have good insurance, then you'll get most, or if not all, of these telemental health visits paid for. So that's the really one good thing. Another good thing about telehealth visits is that if you're on Medicaid, which I'm including in the generous insurance, although I know there's a lot of variation in that, and some very good private insurance companies, they'll pay for the entire visit. So no copay. You don't have to pay the deductible. The telehealth visit will be covered by the insurance. And there are a lot of advocates in Medicare and Medicaid that are really pushing to make it so there's no copay and no hit on your no deductible expenses that you have to pay in order to have these telehealth visits. That being said, there are some institutions that are transitioning away from that. There are some insurance companies that are transitioning away from that. And so the high copays for mental health services that we've seen in the past are coming back. The high deductibles that you have to pay yourself out of pocket before the insurance company starts to pay, those are coming back. So it's going to take a lot of advocacy to make it so that these visits continue to be paid for. These limits on number of visits are coming back. If you hit 8 visits, a lot of insurance companies will say, that's it, you've had enough visits. You should have done what you needed to do with your therapist by now. And obviously that's just not going to be long enough. So we really need to advocate to make sure that insurance covers these visits, which end up being so important.
Great, thank you. Mike, I know that you have been looking at whether people are showing up or not showing up for their mental health visits, and that includes also substance use disorder treatment. Are people who have been engaged in treatment before the pandemic, have they continued to be engaged in treatment using telehealth?
So great question, Dharma. So we at the lab have been working with the electronic health records and trying to see what the impact is of telemedicine. and to see what, trying to assess that once you introduce this, are racial, ethnic, and linguistic minorities inclined, or are they accessing services at the same or higher levels, comparing pre and post introduction of these like isolation restrictions that we had in the state of Massachusetts. And so what we noticed is that the no-show rate essentially decreased between the pre-post period. Most folks started going to more visits, though. However, if you see it in the immediacy, once we kind of like all services transition into telemedicine, there was an initial increase in no-shows just because of you thinking about just the administrative, everything administrative that happens, trying to get the appropriate software, making sure that the people that are going to the visits understand that it's telemedicine and not a in-person visit, things like that. But we noticed that the no-show rate actually decreased over time. And so when we mean televisits here, we're not just isolating it strictly to video visits. We're including phone and video visits. Mm-hmm. So we see that there was a decrease, and we saw a decrease for within all groups. So between pre and post periods, we see that Black, Latinx, and Asian folks all saw decreases in no-show rates. So it shows that folks did, and we also saw that that access to services, meaning at least having one visit, also increased as well for certain populations, specifically for Latinx folks and for Portuguese speakers.
Excellent, thank you. I've been doing also interviews with folks here in Massachusetts, and when I would say that maybe 99% of the people that I've talked to, they say that they have used some form of telehealth, medical health visit, and mostly phone more than video. And when I asked them whether they would prefer to switch to that in the future, almost 100% say no. People continue to have a preference to see their providers, it seems, in person. We are about
I wonder, I'm sorry to interrupt, Dharma. I'm so curious about, and we've talked about this a little bit, but I think we're all curious about those conversations that you've had with the Latino community and during COVID and what the impacts were on mental health. I mean, I feel a little removed from it because I'm always analyzing these big data sets, but yeah. I wonder if you could elaborate on that a little more. Sure. Like, what was COVID like for the Latinos that you've talked to, and how has it impacted their mental health or not? Have they been resilient and strong about it in different ways that you didn't anticipate? Or yeah, I want to turn the tables on you, moderator, if that's okay.
Okay, thank you. So, it's very interesting because we usually do, I'm doing structured survey questions, but I'm also doing, I've done some open-ended interviews. And there's always, as we know, when we're doing an interview, we start, asking general questions, and then we move towards the specific questions, in this case, COVID. And usually when I make that transition during the interview and I say, okay, now let's talk about the impact of COVID-19, and you hear people like, well, there's always that visceral reaction that I get over the phone, and there is this pause, sort of like, them collecting themselves before embarking on these conversations. We've been doing these interviews since summer 2020, and we always think, well, these questions will no longer be relevant because we're coming out of this pandemic. But no, we continue to go back, and then the impact has been actually long-term. My conversations make me believe and that there's a lot of pain, there's a lot of distress, especially because we're talking mostly with individuals from immigrant populations. So they're actually coping with the impact that COVID has had in their lives here, but also back in their countries of origin. It had impacted their ability to support family members back home. They also have had many challenges with having the kids at home, with living in smaller places. I just spoke with someone who told me that the whole family of 6 was living in a 1-room apartment. So many challenges. For the most part, most people have used some form of telemedicine services. They have used mostly phone, and also going back to a comment that you mentioned about health insurance coverage, we are privileged here in Massachusetts with a generous Medicaid program and safety net healthcare systems that have actually supported many of these individuals because they had, a long-standing relationship with primary care physicians or health clinic or neighborhoods. The other important element that had been a significant buffer for the needs that these individuals have experienced during the pandemic. We need to remember that these populations were facing significant inequalities before the pandemic. So the pandemic actually exacerbated these disparities and inequalities, but community-based organizations, food distribution programs have been key in supporting these families. And at least many of them who were already food insecure were able to secure food for the families, and that actually seemed to help. But they almost every single person that I speak with these days, when we ask them looking into the next 3 months, how do you see your financial situation going? And they feel that they still have many struggles ahead. Many challenges. There are mental health issues. There are also physical health issues. People delaying going to see the doctor because of fear of COVID infections, but are now seeing that they should have gone to the doctor earlier. The other important piece is that almost every single person that I have spoken with know someone close to them or a family member who have contracted COVID, and some of them had experienced long-term COVID. So many challenges, and these interviews make it very real. All these headlines that we read, I get to actually hear that, and it brings some level of trauma, as I for them, as they relieve these stories and these experiences, and me on the receiving end, I can hear and feel the pain and the challenges that they face.
Sorry, if I can interrupt, Dharma. We just have a question in the chat by Anna.
Excellent. Okay.
So I wanted to just quickly read that for you. So she
Yes.
said, youth have been negatively affected by the pandemic, and I'm guessing disproportionately in the case of Latinx youth. School counselors and staff are on the front line. Is it possible to imagine more collaboration between schools and healthcare providers, or are there any other creative ways to address this problem?
So I think that we can talk a little bit about that, Ben. We know that, for example, many, if not all public schools have health clinics within the school. So those are opportunities, and we're actually embarking on a study to look into services within schools. Can you talk a little bit about that, Ben?
Yeah. Yeah, it's such a good question. And I have a 12-year-old and 15-year-old going back to school and thinking about all of the new things for them after a year of not really having school last year and it being remote, and now everybody in wearing masks, and the levels of distress and catching up with school and academics. You can tell it's weighing on a lot of people. There are a lot of my kids' friends who are really having difficulty in school. And you add to that all of the things that Dharma was talking about in terms of the family, having stress in the family, having COVID in the family. There's a real concern about mental health with youth and Latino youth, and the real concern about suicide. I really hate to say this, but there are going to be increasing rates, and we're already seeing increasing rates of suicide in Black and Latino communities. So it's so important what you're saying, to get school nurses and guidance counselors in integrated teams with healthcare professionals. So they don't just, when someone comes in who's obviously under distress, they don't just say, oh, you should, and give them a referral. You should go see Dr. Jimenez. They need to be really integrated with Dr. Jimenez in a way that they make sure they get to that appointment, to follow up, to make sure they can get to the second appointment. There needs to be these integrated teams. And so we're trying to work on that. We're trying to do a better job screening, because you know how hard it is for teenagers to go in and admit that they have mental health problems. So we're trying to do a better job screening in ways that don't have a lot of stigma. We're trying to work with school nurses to link them directly with providers at Cambridge Health Alliance. So we're trying to do some things, but there's a long way to go. These are silos. Schools and health systems don't talk to each other. So it's a really important question. There's a lot that needs to be done there.
Anna, good to see you. There are other programs that actually have worked on integrating services for kids where they have providers talking with school partners. But there are other challenges related to that, and is confidentiality. To what extent school teachers can actually talk to counselors, or counselors can disclose private private health information with school teachers or other community organizations that are involved. So there are many challenges, and also integrating the family. And when we talk about immigrant families, language barriers sometimes also add to the complexity of the life that they already are the challenges that they have. So there are multiple levels of factors to consider, but those are very, very important issues that you raise. Just so you have an idea, when we conduct this research, as we're conducting this research and studies on COVID, we do have safety measures because of the level of distress that people experience. There have been calls that we've made that people sound very depressed, or anxious about, social distancing, COVID. So we do have referral resources for them, because, when we go and call them, ask them questions, they get to relieve the trauma of, all these COVID experiences. So it's real, and it's happening every single day. We have 6 more minutes, and I wonder whether someone from the audience has any questions. So then I'll have one last question for each panelist, and you can take maybe 30 seconds, 40 seconds to answer. If you were to talk to a policymaker about what to do about addressing these challenges around mental health services and Latinos, what would you say to them? Who wants to go first?
I'll go if no one else is going to go.
Go ahead.
I would say that, well, one of the things that we need is more providers. And I'm not saying more providers like psychologists. I'm saying more providers like community health workers or peer specialists, where these are folks that understand the community, that may have lived experience, that know how to communicate with the community in ways that even we as providers, even though we may speak Spanish, can't speak to them, because we use jargon. That's what we do. I mean, but community health workers, promotoras de salud, these are folks that understand how to communicate, how to take what we say, translate it, and then really make effective, and then really are able to communicate effectively with the community, and to find ways to make that service reimbursable, right? To pay for that service, because all of a sudden now there just simply isn't enough psychologists, mental health specialists in general to meet the need that is there. And so if we can employ an army of community health workers, all of a sudden our reach is that much greater.
Great, thank you. Ben?
I would second that, Danny. That's really important. And we've worked with a peer support specialists, and they're so important to getting folks to feel comfortable. They almost end up being a separate mental health treatment system. And we should think about peer support and really providing funds and resources for peer support, because it does almost as much as our traditional mental health therapy in terms of helping people heal and telling their story and helping them feel like they belong. And so I second that. I'll take a little bit different tack, and this isn't applicable to a lot of us, but I think the ways in which we police mental health is a huge problem. And the disproportionate incarceration of Black and Latino men, especially with mental health problems, is just a huge policy issue that we have to address. There are so many individuals who have schizophrenia or other externalizing disorders who are out on the street and having difficulty. There are youth who are acting out in schools because of the beginnings of symptoms of mental health problems. And those folks, how the police treats those calls with people who are having mental health problems makes a huge difference in the lives, and it's kind of a fork in the road for some of these folks. And think about a 15-year-old who just got in a fight in school. If that individual ends up in juvenile detention centers as opposed to mental health treatment, that could be the rest of their life. I mean, that is just a huge fork in the road. So I would answer this question. We need to really work with policymakers on making sure good diversion programs are out there for youth and individuals with mental health problems, for those individuals to get treatment as opposed to being incarcerated. And this is a really big problem in the Latino and Black community, especially, and to a lesser extent, some of the Southeast Asian communities, where they're just being directed into jail because the services aren't there, because the police have a lot of racism when they go into those calls and want to put them away. So that's maybe one I would suggest.
Well, we have less than 1 minute, Mike, 10 seconds, because I'm sure that Rosario would like to do some closing remarks.
So great responses from Danny and Ben. What I would say from a 10 quick seconds would be how increased financing of mental health and substance use services. Providers rarely take public forms of insurance for mental health services. And if you really look at the research, most providers that are densely populated areas by Black and Latinx folks are less likely to have clinicians that accept Medicaid. So right there is like a huge access barrier for a lot of folks to access services. Same thing with substance use services. They're less likely to take Medicaid, Medicare in these same areas. So I would say the financing would help out a lot.
And I saw that you have a question, but I would be more than happy to connect with you. I think that advocacy is very important, and I'm sure that we would love I would love for Ben to connect with you and the group, and we could set up another private cafecito with you to talk more about these things.
Thank you so much, Dharma, for moderating this conversation this morning. This cafecito was so interesting and important for our community to be engaged in this conversation. So I appreciate you, Dharma, and also Ben and Mike and Daniel for coming on this morning and bringing this information to us so we can continue making informed decisions about programs, policy, advocacy, and many other pieces of engaging our community and making sure that we are advocating for the well-being of our community moving forward. Again, it was such an honor to have such esteemed speakers in our cafecito this morning. And I think that we need a second one. So we have to plan a second cafecito, not just with Dharma, with everyone again, to continue having these important discussions. And thank you to the audience for your attention and for joining us this morning. Like I mentioned before, this is gonna be shared, the recording, so you can access it and share it with others, but also your questions that you put on the chat and any other comments that didn't get addressed, we'll be happy to share with the panelists so we can send you the responses afterwards. But in the meantime, have a wonderful, wonderful rest of your week and weekend. And we really appreciate you. Gracias por todo. Have a great day. Thank you so much and take care.
Gracias.
Thank you so much.
Thank you.
Thanks, everyone.